Thanksgiving and you're refreshed and ready to get started with skin stuff. So I'll introduce Dr. Trevino to you. He is the chair of the Department of Dermatology here and the co-course director. We are very fortunate to have him with us, and this is the first year that we're doing this together. So we would appreciate your feedback at the end of this process. So we're going to talk about skin cancer for this first hour, and everything you're going to need for your TBL this week is this is part of what your preparatory assignment for that. So just a brief overview of where we're going with the talk today. Dr. Trevino will start out with a little introduction of the topic. We will then move into tumors of the epidermis. We're breaking them down by tumors that are precancerous or can result in invasive cancer. And then we'll talk about squamous cancers, basal cell cancers, melanomas, and end up talking about prevention of skin cancer. So with that, I'll turn it over to Dr. Trevino.
Okay, great. Good morning. So this is an exciting week because I get to talk about skin, which is my job and what I love looking at and helping people with problems with. So hopefully by the end of the week, you guys will feel a little more comfortable with disorders of the skin. Certainly as we go through anything, if you have any questions, please, let me know, or Dr. Krishnamurthy, because I really want everybody to get a good comprehension of the issues that we're going over this week, okay? So the first issue that we picked to talk about is skin cancer, and I think skin cancer is an extremely important issue because as you can see from the slide, it is the most common form of cancer in humans, okay? So obviously it's something that all of us as physicians should be aware of because many of our patients, family members, friends will experience skin cancer. Keep in mind, ultraviolet light is the primary etiologic agent in the formation of skin cancer. So that's something that we'll kind of reinforce as we go along again and again, but just keep in mind that's a major etiologic factor. Nearly 5 million Americans are treated annually for cases of skin cancer, just to give you kind of the scope of the problem. And over the past 3 decades, more people have had skin cancers in the U.S. than all other cancers combined. So again, kind of reinforcing the scope, magnitude, importance of the issue. Whether you're a dermatologist, a family doctor, or any specialty within medicine, you'll likely encounter patients with skin cancer along the way. Basal cell cancer and squamous cell are the most common forms of human cancers. Together they constitute 95% of what we call non-melanoma skin cancer. So when somebody talks about or uses the term non-melanoma skin cancer, they're primarily talking about basal cells and squamous cells. There's some other uncommon varieties that also fall within this, but those two make up the vast majority. And when we think about cancers that can cause death and some very bad outcomes for patients, we're usually thinking about melanoma. So there's about 76,000 cases of melanoma will be diagnosed. Almost 10,000 skin cancer deaths will occur from melanoma, and that's equivalent to about 1 death every hour. Okay, so again, just to sort of bring this problem into perspective, if you think about every hour somebody across the country is dying from melanoma, I think it tells you what an impactful disease that is. Some other general information, 25% of lifetime sun exposure occurs before the age of 18. I think this is a really important fact to keep in mind for anybody who has kids, takes care of kids, knows kids, because certainly if you can impact on that sun exposure early on, you will definitely save them problems down the road, okay? So you really want to start skin cancer education quite early. That's why I think it's great if we can have programs in schools, educate school kids about this, educate parents about it. Our lifetime risk is for developing some form of skin cancer is 1 in 5. So if you look around the room and we count up by 5s, that means a certain number of us here in the room are going to experience skin cancer personally in our lifetime. So again, I think that brings home the fact that this is a very common disease. The risk for melanoma doubles if you've had more than 5 sunburns. So again, that's sort of a personal thing that you have to think about. Are you somebody, or do you know somebody who's had a number of sunburns? If so, they've definitely increased their risk for melanoma. and we'll talk about things they really need to keep an eye on and look for to maybe detect whether or not they might develop a melanoma. So a couple of sun myths and facts. So one myth, a tan is a sign of good health. Often people see somebody with a tan and they think, wow, that person looks very healthy. That's really attractive look. However, I want everybody to know there's really no such thing as a healthy tan. A tan is really an injury response of the melanocytes to too much sun exposure, trying to screen out further additional harmful sun rays. So if you have a tan, you've already injured your skin. Okay, so a tan really isn't healthy in a biologic sense. You can't get a sunburn on a cloudy day. Again, that's a myth because about 80% of the bad UV rays can be transmitted even on cloudy days. So even on a day like today, potentially you're getting some UV exposure. Particularly think about times when maybe you were skiing up in the mountains where it was kind of cloudy. You're getting a lot of UV exposure in those times. So you shouldn't feel like just because clouds are out, you're not going to get any ultraviolet exposure. A lot of folks, especially as you get a little bit older, you may notice some dark brown spots on the skin, and people will say, oh, those are age spots. Everybody gets those as you get older. That's really not true. They're really sunspots. So if you see somebody who's got a lot of brown freckling and lentigines on sun-exposed areas, that's a marker for a lot of sun exposure over the years. So you don't just naturally, everybody doesn't get those brownish discoloration on those areas. That's actually UV damage, okay? So there's a difference in that sense. So what's some of the things to think about for your personal risk for developing skin cancer? Well, one of the main things that we'll talk about is your skin type. And you can see that at some point they went through and sort of made these 6 different skin types to sort of stratify folks as far as their skin cancer risk. So the lower the number, the fairer the skin. So type 1 is quite fair skin, freckles easily, always burns, never tans. And you can see as you move through this, you get darker and darker skin to where you get to type 4, burns minimally, always tans well. Type 6 is black skin. So you should really sort of see where you fall on that spectrum when you see patients. Think about where they fall on that spectrum, and that'll give you one kind of marker for their risk for development of skin cancer. Certainly, we already talked a little bit, alluded to the sun exposure history. If somebody has a frequent history of sunburns, that's definitely going to increase the risk of skin cancer. And you could see even how just a small number of sunburns could really increase your personal risk for melanoma. So a sunburn is a really bad thing. You really want to try to avoid that as much as possible. Numerous moles, nevi, or presence of atypical nevi. So, everybody has a few moles on their body. There's a big spectrum. Some people have maybe under a dozen. Some people have 100 or more. So if you're in that category where you're kind of pushing 50, 100 or more, definitely you're at somewhat higher risk. And it also depends how your moles look. And we're going to talk about what makes sort of an atypical or funny-looking mole. But if somebody has a lot of those, again, those could be markers for somebody who could develop skin cancer down the road. And if you have 2 or more family members who have a history of melanoma, that definitely would increase your personal risk. So be a situation where you definitely want to be screened more carefully for the development of melanoma. Okay.
So here's, we're back to the overview. We're going to start out talking about some tumors of the epidermis. So just some general principles, and this is true for cancers no matter where they happen in the body, right? We have oncogenes, which act in a dominant fashion. So when you have a mutation in an oncogene, it is usually a gain of function mutation, and that leads to increased cellular proliferation. And then we have tumor suppressor genes. So specifically when it comes to the skin, the 2 tumor suppressor genes we'll be talking about are P53 and PATCH. We'll get into a little bit more detail about those. But as the name implies, a tumor suppressor gene is meant to decrease cellular proliferation. So if you lose a tumor suppressor gene, you're going to be more prone to getting cancer. So again, just some basic definitional terms here. We talk about actinic keratoses. They're also known as solar keratoses. This is thought to kind of be the initial stage of sun damage in the keratinocytes. And it histologically is defined as atypia in the keratinocytes that's only involving part of the thickness of the epidermis, okay? And that is as opposed to in situ squamous cell cancers, which involve full thickness epidermal dysplasia. And the reason we separate these is because your chances of developing an invasive squamous cell cancer are higher in an in situ squamous cancer than in an actinic keratosis. Okay?
Okay, so if we think about the epidemiology, we're going to start with, again, the AK squamous cell spectrum, about 700,000 cases of squamous cell per year. I'm hitting the wrong buttons here. 700,000 per year in the U.S., so this accounts for about 15% of all the non-melanoma skin cancers. An individual actinic keratosis has less than 1% chance of progressing to invasive squamous cells. So the thing is that one individual, if you look at each one individually, their risk is quite small, as Dr. Krishnamurthy alluded to. With an actinic keratosis, you just have a few cells that are atypical within the epidermis. However, if you get to the point of the Bowen's disease or squamous cell in situ, that can progress to squamous cell in up to 26%. So I think that makes sense because in Bowen's or squamous cell in situ, you really have full thickness epidermal atypia. So you have a greater kind of bulk of cells that are already atypical. So I think it makes more sense that that would have a much higher risk for development of an invasive squamous cell down the road. So we still tend to treat both of these because I don't know which AK that I don't treat, is going to go on to develop a squamous cell. So we treat AKs, we treat squamous cell in situ because of their potential to develop squamous cells down the road. The risk for squamous cell is related to the amount of UV exposure. And for each one of the skin cancers, it's a little bit different in terms of what type of UV exposure. So for squamous cell, it tends to be the cumulative dose of UV radiation over time is a significant risk factor. So these tend to be more common in folks that have outdoor occupations. See somebody who's a lifeguard, somebody who works on a farm, somebody who works landscaper or other activities where they're outdoors constantly. So they're constantly getting a lot of sun over a period of time, accumulating a lot of UV exposure. And again, your degree of pigmentation is also important, kind of heralding back to the skin types that we looked at. If you're somebody with a low number skin type, very fair skin, you're going to have a higher risk. If you're somebody with a higher skin type, you're going to have lower risk. But skin cancers can occur in folks of all skin types. So I don't want somebody to think, oh, great, I'm a skin type 4, 5, or 6. I'm probably not going to get skin cancer. Statistically lower risk, but definitely still can occur in all skin types. Other risk factors, you can see there's a ton of other risk factors that can lead into squamous cells and AKs. So things like arsenic, which can come like wells. People that live out in the country might have a little arsenic contamination in their wells. Hydrocarbons, ionizing radiation, HPV, which causes, we're going to talk about that when we talk about warts. HPV virus is the cause of warts. So somebody who has a large wart that's been around for years and years and maybe doesn't heal and ulcerates, that can definitely undergo malignant transformation. Cigarette smoking, genetic syndromes, things like xeroderma pigmentosum, where you have genetic defects in DNA repair. Chronic non-healing wounds. If we see somebody, say, with a chronic ulcer that doesn't heal, develops a nodule or knot within it, we get very concerned about development of a squamous cell. And then certainly immunosuppression. I'm going to talk about that in a second. As we're seeing more and more patients that have organ transplants, we're seeing higher and higher risk of development of squamous cell in these folks that generally have long-term immunosuppression. So they have a 65-fold increased risk for development of squamous cells as opposed to the general population. So certainly a huge increased risk in this particular segment of the population, and we definitely need to follow them closely for this. So we often work very closely in conjunction with the transplant surgeons to follow these patients. And many of them develop multiple squamous cells over their lifetime because of their immunosuppression and their necessary because of their organ transplant. The risk increases with the time post-transplant. They tend to develop their squamous cells at a younger age more quickly, and they occur in greater numbers. They tend to be more invasive and locally destructive, and definitely have a higher risk for recurrence and metastasis or spread beyond the skin. So again, if you're involved in transplant medicine, taking care of transplant patients, certainly important to remember that squamous cells are at markedly increased risk in these folks.
All right, so we're moving on to the pathogenesis, which Dr. Trevino has touched upon. The most important risk factor for non-melanoma skin cancer is UV light, sunlight, resulting in damage to DNA. So normally, whenever you get DNA damage in your cells, we have mechanisms in place to prevent that cell from growing, right? And P53 is one of those things. It's thought that in patients with squamous cells and AKs, the DNA damage actually leads to mutations in P53. So along with the damaged DNA, you're also preventing your normal cellular mechanisms that prevent apoptosis, right? So you have damage to the cells. And the other thing that sunlight often does is it inhibits function of Langerhans cells. You remember from your CATOs, Langerhans cells kind of sit in the epidermis, and they're kind of the macrophages, right, in the skin. So they usually eat up damaged cells. Now, if you have decreased Langerhans cell function along with damaged DNA in these cells, you're more likely to get them proliferating, and that will lead to cancer. Now, the second risk factor, which Dr. Trevino has been talking about, is patients with organ transplants or other causes of chronic immunosuppression. Okay, these patients are at risk of developing oncogenic viral infections like HPV infections, which, again, you remember from POD last year, HPV, the DNA integrates with the host genome, right? And depending on where that happens, that can interrupt your normal cell cycle control and result in increased cellular proliferation. So this is, it kind of looks a little complicated, but it's not. This is normal role of P53 in your cells. So P53 is supposed to get activated in response to cellular damage, either from hypoxia, from DNA damage, and normally P53 works in different ways to cause arrest of the cell cycle at the G1 phase, which then gives your enzymes time to kind of repair that DNA damage, and eventually it can result in apoptosis of the damaged cells, right? So patients who have UV-related mutations in P53 obviously cannot undergo this process. So their cells, even when they are damaged, will keep proliferating. So abnormal cells proliferating is going to eventually lead to squamous cell cancers and actinic keratoses. Now, Dr. Trevino also talked about xeroderma pigmentosum. This is a genetic syndrome. It's autosomal recessive, and it is mutations involving enzymes that are important in DNA repair. So nucleotide excision repair enzymes. Okay, so this pathway is kind of similar to the P53 pathway because, when the abnormal cell is arrested in its growth, this is where the nucleotide excision happens, right? So if P53 is working but you don't have those enzymes, you're kind of in the same place where you still have that abnormal cell that can keep proliferating, right? So patients with xeroderma pigmentosum are also prone to getting non-melanoma skin cancers. So that's your squamous cell cancers, your basal cell cancers, and they can also get melanomas.
Okay, so as far as our clinical presentation for actinic keratosis, we really want to look on areas where folks get a lot of sun exposure. So we look on the face, the scalp, the forearms, dorsum of the hands, areas, as I said, where you're chronically getting a lot of UV exposure, and these will present as erythematous or brown macules or papules that have a rough sandpaper-like texture. So they're like red spots that have a really rough surface to them, and we'll show a picture here. So this is a forehead, an area that gets a lot of sun exposure, and you can see this focal area here that's kind of red, a little bit raised, and then you've got your scale on there as well. Okay, so that's certainly different than the rest of the surrounding skin. That's an actinic keratosis. We can see similarly here on the cheek, another area where you get a lot of UV exposure. You've got your erythema, slight scale here, kind of that rough sandpapery feel. And somebody's typically going to come in and say, hey, this doesn't go away. I've had this now for 6 months or maybe a year. It doesn't really want to go away. I'm concerned about it. What do you think it is? And we'll look at this and say this is an actinic keratosis. It's a precancer lesion caused by too much ultraviolet exposure. This is a good example of, so oftentimes folks will have lots of actinic keratoses, and we need to figure out a way to treat them all. Well, one of the therapeutic ways we may treat them is with a topical solution of 5-fluorouracil. And 5-fluorouracil kind of targets those higher dividing cells. So it sort of specifically lights up or targets where folks have actinic keratoses. So you can see this extensive actinic keratoses here and here that have really been highlighted by this treatment. And people are often amazed at how much sun damage they have when they start treating with this, because maybe just to the naked eye it doesn't look quite so bad. But when you start to treat with this particular formulation here that, like I say, kind of highlights those metabolically active cells, you can really see the extent of the actinic keratoses in many folks.
Right, so now we're moving back into, yes.
Yes.
So you put it all over the face and you have one
No. If somebody has, that would be what we call a field treatment. So if somebody has multiple AKs, we would have them apply it to a certain area. So say we thought on their scalp they had a ton of AKs, some of which were quite visible, some of which were like, it looks like you probably have some more, but we can't really localize those. We'd have them do a field treatment of that particular area. And if they just have limited, I'll talk about this in a second, but we usually use something called cryotherapy where we freeze them if they just have a limited number. Yes, sir. She had enough sun damage that we felt like she needed to have a field treatment as opposed to like a local treatment. So if somebody has just, say, a handful of lesions, then we would probably treat them locally with freezing them. If they have a number of lesions, like a dozen or more visible lesions, then we would often talk to them about a field treatment. And that would be what that 5-fluorouracil is.
It's interesting. My brother-in-law, he was given this treatment, the 5-fluorouracil, to put on his face because he's Caucasian, and they thought he had a bunch of actinic keratoses, and he went out in the sun with this stuff, and he came back. His whole face was completely bright red. I should have taken a picture of that to show you guys. So when you prescribe this to your patients, make sure you tell them,
do not go out
in the sun.
Yeah.
Okay, so here's we'll do a brief review. Yes?
How long do they have to use that?
Depending on the body area, it's usually a couple weeks. So usually start 2 to 3 weeks. We'll see them back, see what kind of response they have. Sometimes, particularly on a forearm or back of a hand where some of them are quite thick, they may have to go like 4 to 6 weeks.
Okay, so we'll do a little brief review. This should all be familiar to you, right, from Cato's. All right, so different layers here of the epidermis. At the very top, what's that layer called? The keratin layer, your stratum corneum, right? And I want you to notice that you don't have nuclei normally at the top here, okay? And then below that, you've got these cells with the granules in them. What do we call that? The granular layer. And then we have the majority of the epidermis here, all these keratinocytes. That's just stratum spinosum. And then at the very base here, you've got cells that are kind of standing up. That's your basal layer, right? And the basal layer is where your melanocytes sit. In normal skin, you can barely see the melanocytes. Here's one, here's one, here's one. But we'll look at the melanoma and you'll see how it looks really different. And then we're down in the dermis. You've got the papillary dermis at the top and the reticular dermis down here. All right, so now that you know what normal looks like, let's look at an actinic keratosis. This is an actinic keratosis. You can see, I mean, on this side of the screen here, this is kind of a bit more normal. And all of this is abnormal, right? So if we start at the top, you'll see that the keratin is very thick. So we call that hyperkeratosis. The keratin has nuclei going all the way up to the top. So that is parakeratosis. So on the right-hand side, this is a bit more of what normal keratin looks like. It's kind of loose, doesn't have nuclei. So in an actinic keratosis, you often have too much keratin, and it sort of skips over the areas where the cells are atypical. And it actually kind of makes sense if you think about the clinical appearance of those little spots. They were rough, right? They were scaly. And they're scaly because the keratin layer is really thick. Okay. And then the important part, the thing that makes it an AK, is the fact that you have atypical cells involving the epidermis, but it's only part of the thickness of the epidermis. So we're starting down here at the base. You're seeing that these cells are kind of large. They're dark. And instead of just sitting, like here's your normal, right? Instead of just sitting like this, they're sort of flattening out. They're kind of disorganized. They're jumbled up. They're large, dark, atypical cells, but it's only part of the thickness. At the top, it gets normal again. Okay, so that's an AK, partial thickness, squamous atypia. Oh, and the other thing here, this bluishness in the dermis, we call that solar elastosis. That's what happens when you're out in the sun a lot and you don't use sunscreen. The elastic fibers degenerate. So this is just a sign that, there's been sun damage to the skin. This is just another view of the same thing. Keratin layer is too thick. You've got some parakeratosis. And the key here are these kind of large, dark, atypical cells involving just part of the thickness of the epidermis. This is just a diagrammatic representation of what we've talked about. This is the progression of squamous dysplasia. So if this is your normal basement membrane, here's your epidermis, here's your dermis. In an actinic keratosis, it's partial thickness atypia. So your dysplastic cells are going to be part of the thickness here. When these cells involve the entire thickness, we call that an in situ squamous cancer. And once the atypical cells invade the basement membrane, now it becomes invasive, okay? So with that, we're going to move into in situ squamous cancers, or Bowen's disease.
Okay, so Bowen's disease tends to present as a solitary, sharply demarcated pink to erythematous plaque. Sometimes it's misinterpreted as like a patch of eczema or a patch of tinea or fungus infection. Or even psoriasis. So typically somebody will come in and again, they'll say, I've had this like red scaly patch on my finger or my hand or back or on my arm, maybe for months or a year. I've tried a number of different topical treatments to it. It doesn't go away. That should be a tip-off that maybe there's a little more going on than some, just random, say, dermatitis or fungus infection, because usually those should respond to appropriate treatment. So this would be a good time to just interject. If you have a lesion that you've sort of made a tentative diagnosis with and implemented therapy and it's not responding, that's always a good time to kind of step back and say, ooh, did I make the right diagnosis, and what else could I do to maybe help make that diagnosis? And in this case, maybe a biopsy would be very helpful and appropriate. So here's a case of Bowen's disease on the back of the hand. Again, you've got sort of this plaque that's got a little bit of an open area here in the center. So again, it's probably been there for a long time. Maybe somebody's tried several types of medicine on it, doesn't want to heal. Again, a tip-off that something maybe is going on there that needs further investigation. This is a plaque of Bowen's disease on the side of a finger here. Again, sort of this erythematous, scaly plaque. Treated with several different types of medicines, not resolving.
Here we are back to the path of squamous cell cancers. Yes?
Like always on the back of the hand,
Pretty much in any sun-exposed area. And I'm sure there have been cases reported on areas that don't get a ton of sun exposure, but typically sun-exposed areas. So the face, back of the hands, arms, forearms. Yeah, any area like that. Yes?
would that be painful?
Depending on it, may not necessarily be painful, if it isn't like secondarily infected or anything like that. It may just be more annoying or concerning because it's like, why doesn't this thing go away?
Okay, so this, you already know what this is going to look like under the microscope, right? It's full thickness dysplasia. So you see these big, ugly, dark cells. They're not just at the base anymore. They go all the way up to the top. So full thickness dysplasia, squamous cell carcinoma in situ. As we talked about at the beginning, these lesions have a much higher chance of progressing into invasive cancer than those actinic keratoses that we looked at. But let's talk about, so here's your basement membrane, right? It's kind of right at the intersection of the epidermis and dermis. So what are the chances that this thing is going to metastasize? Right, so it's pretty close to zero, right? Because if you think this whole lesion truly is an in situ cancer and you have not missed an invasive focus, you have not breached the basement membrane. And where do the blood vessels live in the skin? Do they sit up in the epidermis? No, they sit down in the dermis, right? So you pretty much have to breach through that basement membrane in order for your atypical cells to have access to the blood vessels in order for them to metastasize. So in situ squames tend to not metastasize because they haven't gotten to the blood vessels yet. So complete excision is usually curative for those.
Yep.
So we're moving on now to invasive cancers.
So squamous cell can develop on chronically sun-exposed areas as well as other sites that are lined by squamous epithelium. So you can't get squamous cells other than the skin on other mucosal surfaces. Common sites on the skin, again, are going to be areas where you have a lot of sun exposure. So typically head, neck, extensor arms, backs of the hands. This typically will present as a skin-colored or erythematous nodule. Oftentimes it's got a ulcerated or open area within it. And again, it's one of those things that it just won't heal. These are slow-growing tumors for the most part. So somebody's probably had this for months, a year, or longer. And again, it's one of those things that just doesn't heal up. And that's typically what eventually drives them to come see the physician, is that it won't go away. So again, you can see sun-exposed area. You can see this erythematous nodule with a little bit of scale here in the center. This is a little more dramatic example. So you have a rather large nodule that is ulcerated or open in the center here. And again, on a typical sun-exposed area, representing a squamous cell cancer in both cases. And don't forget about, again, mucosal surfaces. So a mucosal surface that gets a ton of sun exposure is your lip. Your lower lip tends to get a little more sun exposure than your upper lip. So whenever we see ulcerated areas on the lips, then I get really concerned about it, especially if it doesn't want to heal, promptly with some therapy. Then we think about squamous cells. And again, we'll talk about this a little bit more as we go on, but I'm particularly concerned about squamous cells on the lip because they tend to have a higher risk for metastasis to distant sites, okay? So again, don't forget about your lips. So when you're thinking about sunscreen for your skin, think about a lip balm with sun protection for your lips as well, because people can get skin cancers, typically squamous cells on the lip.
Question?
As opposed to
Probably, potentially. And the other thing is Bowen's tends to be a little flatter because if you think about it, it's in situ, so you don't have that bulk of cells. Whereas most of the examples I showed you there, the squamous cell tends to be more like a raised, like a nodule. So it tends to be a little bit larger lesion and potentially a deeper lesion. Yeah, I would say, again, it depends. Some folks do have pain. It's not really a thing that would make a big difference in me making that diagnosis. It's more of a clinical appearance and a natural history of the disease. So yeah, it could be, but not necessarily. Pardon me? Again, typically by the time it's a squamous cell, as Dr. Krishnamurthy is going to show you on PATH, you're going to have an invasion and a bulk of cells there. So generally, if it's a squamous cell, it's going to be a little more raised. So maybe a papule nodule. But the ultimate diagnosis is going to be the pathologist. I mean, it may look relatively flat, but it still could be a squamous cell. So if that's in my differential, a lot of times we'll biopsy. Like I might biopsy this, and I may say, is this an actinic keratosis or is it an early squamous cell? I don't know. I don't know clinically for sure. But how am I going to know for sure? I'm going to send the specimen to Dr. Krishnamurthy, and she's going to tell me. So that's how we know. That's how we work together to help our patients.
All right, so talking about the path, if you get a biopsy, well, this is actually a larger excision of a lesion like that, you can see here we've got these big islands of squamous cells down in the dermis where they don't belong. So this is what a squamous cell cancer looks like, right? Here's your epidermis on top, and you've got these big irregular islands of squamous cells, and you know these are squamous cells because they have a lot of pink cytoplasm. Okay, and we'll look at a higher power here. You have these little whorls. This is keratin. The pink little keratin whorls, they are supposed to kind of be pathognomonic. This is what you usually see in really well-differentiated squamous cell cancers, which is most of them in the skin. So this tumor that's forming keratin, you know, comes from keratinocytes, so that's a squamous cell cancer. And it's down in the dermis now, so you know this has a chance to get into the blood vessels and metastasize. And just a quick side note too, you guys were asking about when are lesions flat versus when do they become nodules. In general, I would say whenever a tumor starts invading into the dermis, it has a higher chance of becoming a nodule. It's more elevated. And that's a theme we'll see as we talk about nevi in the next hour. Yes, the whorls are, or the keratin pearls, whatever you want to call them, it's this stuff, this pink stuff in the middle. This is your keratin, all of these. Yes, it is. But really, the diagnosis is based on the fact that you have atypical squamous cells down in the dermis. They're not just in the epidermis anymore. And the way you know they're squamous cells is because you see all this keratin that they're forming. Okay.
Okay, so when we think about the metastatic potential for squamous cell, I would ask you guys to think about our three major types of skin cancer we're going to talk about. Squamous cell I'm going to put kind of in the middle. Basal cells that we'll talk about in a few minutes hardly ever metastasize. It's kind of a rare event if you have metastatic basal cell. Melanoma that we'll talk about a little bit later certainly has a very prominent metastatic rate depending on its depth. So that would be kind of at the one end, and I put squamous cells sort of in the middle. So overall, squamous cells have about a 3% metastatic rate, which is pretty small. So I mean, for most folks, not all folks, but most folks with squamous cell, you can reassure them this is a local disease. We will use local treatments to eradicate it. However, certain areas tend to have higher metastatic rates. So we talked about mucosal squamous cell has a higher rate than that on sun-exposed skin. So the lower lip that I showed you before can have a metastatic rate 15.8%. That's pretty high. And squamous cell of the genital area is also very prone to metastasize. So again, you have to sort of triage those patients out from your general group of squamous cell. Generally, the metastases go to the regional lymph nodes, but occasionally distant hematogenic spread can also be seen.
So with that, we're now going to move into basal cell cancers.
Okay, so basal cell is the most common tumor affecting light-skinned folks. Its incidence is increasing. You can see approximately almost 3 million cases in the U.S. per year. Age of onset, generally over 60, so we tend to see it in folks as they get a little bit older, have accumulated a lot of sun exposure over the years. However, keep in mind that depending on your level of sun exposure and skin pigmentation, I have seen basal cells in folks that are like in their late 20s or early 30s. And these are typically folks that are maybe very fair-skinned, worked as lifeguards or worked on a golf course or something, a landscaper, out all the time. So, you know, certainly I don't disregard the diagnosis of a basal cell cancer just because somebody is of a younger age group. Okay, so typically older folks, but certainly other factors can cause them to appear earlier during somebody's lifetime. A lot of the predisposing factors, I'm not going to read all these because they're kind of an overlap with the squamous cell. You can see there's a lot of the same factors that we talked about before. Again, the UV exposure patterns may be a little different with basal cell. It's related directly to intermittent sun exposure and overexposure. So again, maybe somebody who's gone down to Florida a few times, gotten a few sunburns, and then somebody who's also happens to work outside, has an outdoor activity where they get a lot of sun overexposure all the time. But again, a lot of the same factors that we see. Again, immunosuppression is going to cause an increased risk of basal cell, but keep in mind, important fact to remember that even though basal cells are more common skin cancer, in that immunosuppressed transplant setting, the squamous cell risk goes much higher than the basal cell risk. They both go up, but that squamous cell risk, as I showed you, was like 65 times normal. So in those patients, squamous cell actually becomes the predominant one, even though overall basal cell is the most common skin cancer among all folks.
So pathogenesis of basal cell cancer, once again, it's related to sunlight, and similar to squamous cell cancers, when we talk about sporadic basal cell cancers, which is what most of them are, right? The most common mutation there is, again, going to be inactivation of P53. The other mutation that you can sometimes see in sporadic basal cells involves mutations in the patch tumor suppressor gene. So we'll talk a little bit more about that because this is the main gene that is mutated in people who get this inherited basal cell carcinoma syndrome. It's also called the Gorlin syndrome. And I actually saw a patient with this in my fellowship. He presented with a whole bunch of basal cell cancers. These patients are also at risk of getting certain skeletal abnormalities. I don't expect you to know all the details, but just know it's kind of a systemic process. It involves more than just the skin. And it's kind of a similar pathogenesis as retinoblastoma. If you remember, that's a two-hit hypothesis, right? So you're born with a mutation in one allele of the patch gene, and over time with sun exposure, you get the other allele being mutated as well. So once you've lost both of them, now you're at increased risk of developing skin cancer through increased signaling of this sonic hedgehog pathway. So we'll look at this pathway. Okay, so patch gene can be mutated in both sporadic and inherited basal cell cancers. It is the most common mutation that you see in inherited basal cell cancers, and the second most common mutation in sporadic ones. All right, so this diagram kind of shows you what's happening in the body. This is the normal sonic hedgehog pathway. Okay, so on the left-hand side here is a normal cell. We have the patch receptor. It's a receptor that sits on the surface of your cells, and it's normally coupled to another receptor called smoothend. Okay? In the normal cell, when you have binding of the sonic hedgehog to the patch receptor, the smoothend dissociates from it, and it is now active. So this can now lead to signal transduction, and you have increased cellular proliferation. But in normal people who don't have mutations in the patch, this coupling is, the uncoupling is sort of based on binding. It's ligand dependent. Versus somebody, if you think about what might happen if you have a mutation in this patch receptor, the smoothend is constitutively active. So you don't need that sonic hedgehog to bind anymore. This is always sitting and activating your genes and leading to cellular proliferation. Is that making sense? And the reason we're talking about this is because we actually have therapy which is specifically targeting this pathway. So we now have drugs that inhibit the smoothend receptor and thereby decrease your incidence of basal cell cancers.
So our clinical presentation of a basal cell, these are limited to skin containing pilosebaceous units. It's usually on the face, often on the nose, is the typical area where we see them. There's a couple of different variants of basal cell. The most common is something called a nodular basal cell. This is the most common subtype. Typically presents as a smooth surface papular nodule. Oftentimes it'll have a central ulcer crust, and it often has very prominent telangiectasia. I'll show you a classic picture. They also tend to have this translucent, kind of raised or pearly border, and those are very characteristic of a basal cell. So as we look at this picture, I really want you to sort of fix this in your mind, because I think this is a really classic appearance of a basal cell. So again, some of the characteristics on a sun-exposed area, you've got this sort of translucent papule, you can kind of see through it, and then you've got these prominent telangiectasias, these prominent dilated blood vessels running through it. Again, as they get bigger, a lot of times in the center, they'll get like a little sore or ulcerated area, which can also be a clinical clue. But this is a very typical appearance of a basal cell cancer. This is a basal cell, and you can see this rolled border, pearly border that we talked about before. So you've got kind of a central ulceration here, and then this rolled, well-defined border. Again, we're going to talk about basal cells have a very low metastatic rate. So can we cure this for this patient? Absolutely. Will there be some morbidity? Absolutely. I mean, if you think about having to cut out a tumor here with a margin and then repairing this and all the important structures around the eye and the tear ducts and all that, definitely you're going to have some morbidity with this. So even though many, the majority of folks that have skin cancer don't die from it, there certainly can be a lot of morbidity. And if you think about a large scar on a very cosmetically sensitive area such as this, again, that's going to be a lot of morbidity for this particular disease. Again, another large basal cell that's really ulcerated in the center, got this thick crust, and again has sort of this well-defined border to it. So, and again, if you think about, potentially treating this, certainly very treatable, but probably rather extensive surgery here. That's going to involve either like tissue transfer or possibly a graft or, potentially several surgeries in order to remove and repair this defect. So again, somebody's going to have a very significant cosmetically visible scar to get rid of this. Some other less common subtypes of basal cell, and I'm just kind of showing you this because if pretty much for every skin disease we talk about, there's a typical variant, which I just showed you, but there's also variations on a theme, okay? So not every basal cell is going to look like the one I just showed you. So as a dermatologist, I need to be aware of the fact that there are other varieties. As a doctor, you might also want to know that there's some other varieties out there to think about in case you see these. A superficial basal cell tends to occur on covered areas, which sounds like a little weird because you think, isn't it always sun exposure? Obviously, we showed there's a whole lot of other factors that can cause basal cells, so they're not always on sun-exposed areas, and these tend to appear as erythematous plaques with an atrophic center and elevated border. So say you see something under somebody's shirt that they have kind of a persistent red area that looks a little depressed, doesn't go away. Think about a basal cell there, even though it's not typically in a sun-exposed area. Pigmented basal cell. Certainly, some basal cells will have a significant amount of pigment in them, and they'll look dark. So I've certainly biopsied things saying, I'm not sure if this is a pigmented basal cell. It may be a melanoma. So this is something that could actually clinically look like a melanoma. And a lot of times we'll say, oh, we really hope this is a pigmented basal cell. And when it comes back as that, we kind of have a relief because certainly basal cells are easier to treat, lower risk than melanomas. But you can have a variety that looks very similar to a melanoma. A morpheoform basal cell can look like a scar. So somebody may come in with like this depressed scar-like area on their face. And I'm like, hey, did you have some trauma there, injury there, surgery there? No. But they have this rather prominent thing that looks like a scar on their face. Then I have to think, is this a basal cell? Is it one of these morpheoform basal cells? And these can actually be fairly difficult to kind of track out and excise. So again, those can be a little tricky in terms of treatment. And then there's this one called a fibroepithelial fibroepithelioma of Pincus, which can occur as multiple papule nodules on the lower trunk. So if somebody comes in, again, has these persistent little bumps on their lower trunk, don't go away, we might want to biopsy those, find out it's a basal cell. So again, you have your typical basal cell that I showed you initially, but there's variations on a theme to at least be aware of.
All right, so here's the path. I think the path for a basal cell cancer is very characteristic. This was one of the first tumors that I ever learned how to diagnose under the microscope, so I have a special attachment for basal cell cancers. And I just think they're really beautiful under the microscope. And this is a theme that you'll see in a lot of skin diseases, you know, like you'll see it grossly. I mean, it looks gross sometimes, right? But under the microscope, everything looks different. It looks prettier. Okay, so here's your basal cell cancer. You've got these nodules of blue basaloid cells. So when we say basaloid, we're talking about cells that are small. They have very little cytoplasm. So most of what you see is the blue, which is the nucleus, right? So you've got these nests of blue cells. They often have what we call a retraction artifact, or this area of clearing around the nest. And that's just an artifact that happens with histologic processing. And it happens because a basal cell, the stroma, often has a lot of mucin in it. So the stroma easily falls apart. And so this is something that we can actually use to make this diagnosis, the fact that you have this cleft around the nest. And the other characteristic is what we call palisading of the nuclei. So palisading, or standing up like a picket fence on the periphery. So you see how these cells are kind of lining up? That's the palisading of a basal cell. So look for a blue nest with retraction artifact and palisading, and you have a basal cell cancer.
So as I said, in terms of our metastatic rate, basal cells are really low, 1 in 1,000 to 1 in 35,000. So again, for your typical basal cell, that's really not an issue to think about metastatic risk. However, in somebody who has a very large aggressive tumor, or where you get tumor cells into the nerves, so-called perineural spread, there actually is a metastatic risk in those cases. So we certainly think about that if we get a biopsy back and it talks about perineural invasion, or if somebody comes in. And some folks will tend to neglect or deny their lesions. They're kind of like, well, I know I've had this for 5 years, but maybe it's going to go away, okay? So it gets bigger and bigger and bigger, it doesn't go away. So again, one of those very large, ulcerated, aggressive-looking basal cells certainly could have a risk for metastases. So in those particular cases, we would address that. There is, however, a high risk of recurrence with lesions on the nose, ears, and periocular areas. And that really drives our choice of therapy for those areas, because what we'd like to avoid, if possible, is sending patient in for surgery to have it cut out, and then 6 months or a year later, they start to develop a recurrence in that area. So knowing that, there are certain things that we may tend to suggest in these areas, and one is a procedure called Mohs surgery that we'll talk about a little bit as we go into therapy. So I think this is my slide. Okay, so,
Yes.
So evaluation for patients with suspected non-melanoma skin cancer, pretty much like any other patient you're going to evaluate. You want to get a good history, do a good physical exam, and a biopsy. And we'll talk a little more. Don't get too hung up at this point about the biopsy terminology, but if it's a shallow process, for example, if it's a superficial basal cell or squamous cell in situ, something called a shave biopsy is generally very adequate to make a diagnosis. So shave biopsy is where you anesthetize the skin, take a blade, and basically shave underneath the lesion. And again, we'll talk about this a little bit more later in the lecture. But on the other hand, if you think it's a deeper lesion, or if it appears to have more substance to it, sometimes a punch biopsy is going to be a better choice. And a punch biopsy is where you anesthetize the skin, take an instrument that looks like a little cookie cutter, and basically take a little core out of the center, and then suture up the lesion. Okay, so they're just two different ways of obtaining tissue. And there's certainly a lot of caveats to what I just said. But the main thing is that you want to work with your pathologist because I need to provide the pathologist with a good specimen, or the pathologist can't provide me with a good diagnosis. If I give them a bad specimen, I can't expect them to turn it into a beautiful thing, right? So I have to give them a good piece of tissue so that they can give me a good diagnosis so then I can help my patient. So there's a lot of caveats to this, but those are just some general ideas as far as what type of biopsy you might make. Therapeutic options, again, this really isn't about turning you guys into experts in treating skin cancers. But for non-melanoma skin cancers, I just want you to be aware there's a huge number of options. So for your really superficial ones, there's a procedure called curettage and electrodesiccation, basically where we kind of scrape and burn. So that might be appropriate for, say, a Bowen's disease. Some folks with Bowen's disease don't want to have surgery. They don't want to have a cutout. So you might do a C&D, okay? Excisional surgery, or basically cutting it out with a safety margin, is a very standard way to take out many of the non-melanoma skin cancers. I talked about Mohs surgery. Mohs surgery is named after a guy, Frederick Mohs, developed Mohs surgery. It's not an acronym. It's somebody's last name. And this is actually a margin-controlled surgery where somebody comes in, they take out a layer of the skin cancer, and then they make a little map, and then they process the specimen, and they look at all the margins. So they look at the side margins, the deep margin, and they make sure that they've cleared the cancer. If on the map one of the margins is still positive, then they know they need to go in and take a second stage of that, where the tumor was positive. And then they make another map, and they keep going until they've cleared the tumor. So it can sometimes be an all-day process. It's an outpatient surgery, usually done in a surgery center in somebody's office, or perhaps it's attached to a hospital. But it's outpatient procedure, and if it's a single stage, it may just take a couple hours. They know they're cleared, they go ahead and close it up, send you home. But some folks have larger tumors, and they may take 3 or 4 stages, so it may be an all-day affair. I know they've actually had some folks that have big enough cancers that they have to put a bandage on and bring them back the next day and do some more work on them. So again, this is where you don't have a lot of tissue, and you need to make sure that you go ahead and excise, but you don't want to sacrifice a lot of normal tissue. So we talked about areas like your nose, your ears, center face area. Radiation therapy is also a good alternative, particularly for older folks that don't want to have surgery. If you have an older patient that does not want to have surgery, radiation therapy is certainly a viable alternative. Photodynamic therapy is something that we do for patients that have large numbers. It's one of those field therapies for actinic keratoses. So somebody who has large numbers of actinic keratoses, photodynamic therapies where we have them come in, we put a photosensitizer on their skin, tell them to bring a book because they need to sit there for an hour while the photosensitizer kind of soaks into their skin. And then you expose them to a blue light that activates the photosensitizer, and so it serves as a field treatment. So as opposed to using, say, that cream that I showed you where that lady got red all over, instead of doing that for 4 to 6 weeks, she may say, hey, I'd rather come in the office, have the photosensitizer put on, sit under the blue light for 16 minutes, and have a photodynamic therapy. So again, it's just different options that you can offer patients. And then topical chemotherapy, we talked about the 5-fluorouracil already, and then there's some immune response modifiers that there's one treatment that we'll talk about again when I talk about warts, because it sounds kind of weird, but it's used for skin cancers and warts, both on the theory that it alters the immune response. And this is a medicine called imiquimod. It's an immune response modifier. And again, it helps your immune system attack certain types of skin cancers. In this case, superficial basal cells are something that can be treated with a topical therapy called imiquimod. So I don't want you to think that all skin cancers could be treated with creams, but there are certain subtypes that might be amenable to treatment with a cream. Again, important because not all patients want to have surgery. A lot of folks will do pretty much anything not to have surgery. So it's nice to have non-surgical options to offer folks. And then Dr. Krishnamurthy alluded a little bit to this treatment. It's called Vismodegib, or Aravedge is the name of this treatment. And this is indicated for adults who have locally advanced basal cells who are not candidates for surgery or radiation, or for patients with metastatic basal cell. So this is going to be really applicable to a small number of patients, but for that patient who really doesn't have a resectable tumor or who has metastatic basal cell, this therapy can be very effective. And the mechanism she talked about involves inhibition of the hedgehog pathway. So it's kind of cool to see something with a molecular basis actually come to the clinical realm where we can use it because we know exactly what it's doing. So for these particular patients with these very large advanced or metastatic basal cells, this is another therapeutic option we can offer them. Certainly you can see that it does not come without side effects. And then it's actually got a box warning, so you're definitely not supposed to use it in women who are of childbearing potential or certainly who are pregnant. Okay, so, but it is a new therapeutic alternative that we have for folks with advanced and metastatic basal cells.
So with that, we're going to move into tumors of melanocytes. Any questions so far with the keratinocytic things?
Question?
I have a question about the photo that you did.
Uh-huh. Well, you have the photosensitizer actually sort of preferentially targets those rapidly dividing precancerous cells. So it actually helps the blue light, which is therapeutic, to focus on those areas. So it's preferentially taken up by those cells. And so when you apply the light, that's what you're treating. It's definitely like, yeah, inactivating, killing those cells. Yes. Question?
What's the etiology of vaginal?
What is the etiology?
Like that's generally not.
Right, but as you saw, there's like a lot of other factors. I would think that a lot of times that might be actually HPV related because a lot of people get warts or wart virus, and that's also a factor. So just remember that even though we're kind of focusing on these cancers being UV produced, there's a huge list of factors. You know, anything from infectious, environmental, genetic factors. So a lot of different factors that can play into those.
Yeah, that's an excellent question. It is HPV related, the high risk HPV usually that gives you vaginal and cervical squamous cell cancers. Mm-hmm. And you'll learn more about that in the reproductive course. All right. So melanoma.
Okay. So moving along then, melanoma is worldwide incidence is increasing faster than any other tumor. So this is a good one that you guys should be up to date on. The lifetime risk of an American developing melanoma is currently about 1 in 50. So again, if we kind of count up in the room, statistically, there's going to be, somebody in their lifetime is probably going to develop a melanoma. So this is pretty striking because maybe, say, 20 years ago, it was like 1 in 1,500, okay? So it's really zoomed up from like 1 in 1,500 to 1 in 50. One person dies, we kind of said this before, of melanoma every 57 minutes. So about every hour, somebody is dying from melanoma, which is a pretty sobering fact. So I think this is a call for us as physicians to really address this disease and try to reduce the incidence of it and catch cases early on. It is the most common type of cancer in young adults. Deaths from melanoma occur at a younger age than most other cancers. So again, early education about it, prevention, and early detection are really our keys to attacking this disease. One of the biggest factors that we'll talk about is the depth of the cancer, referred to as the Breslow depth. So survival for stage 1 melanoma, Breslow depth of less than 1 millimeter, is about 98%. So I think that, again, reinforces that if we catch this early, it's a very treatable disease. So we always feel really good if we catch an early melanoma, are able to excise it, and then our patients able to go on and live a very long and healthy and great life. I always feel really bad when somebody who's had one for a couple years comes in and it's a deep melanoma, and we know there's going to be a lot of additional issues associated with that. and actually seen folks who have died from their melanomas because of metastasizes. So again, our opportunity to prevent that is to try to diagnose these as early as possible. So risk factors, again, there will be a lot of things that are overlap with some of the other things we talked about. Certainly genetic markers, there's a gene CDKN2A, so mutations in those are associated with familial melanomas. Again, the idea of somebody with very lower amounts of pigment in the skin and hair, so your blonde red hair, your pale light skin, Northern European ethnic origin are all risk factors. Intense intermittent sun exposure, especially at a young age. So I think you remember from one of my introductory slides, if you had 5 or more sunburns, you definitely increase your risk for melanoma. So that kind of really intense burst sun exposure, coupled with somebody who's maybe got really light skin, is definitely going to increase your risk. Family history, usually 2 or more first-degree family members with melanoma would be a significant risk factor for somebody. And then we also talked a little bit about the increased numbers of benign nevi, more than 50. So just having a lot of moles kind of puts you at somewhat higher risk. Also certain types of moles. So dealing with folks of all age, I see newborns and infants. So I see kids with these large or giant congenital nevi or really large birthmark moles. So those have a high risk, or a significant risk, I should say, of turning into melanoma over somebody's lifetime. So we generally will recommend that those be excised, either in stages or a single surgery if possible. And then if somebody has so-called dysplastic nevi, so those are nevi that are moles that just don't look right. They're usually kind of larger, they're usually a little irregularly pigmented, maybe a little irregular border to them, a little asymmetric. So they don't have all the features of just a normal benign mole. And some folks have tons of dysplastic nevi. I mean, that's what they tend to make. So in those folks, it's a real challenge to follow them and try to make sure that they don't develop anything that is too concerning. Immunosuppression, again, can be a risk factor. So again, in your organ transplant patients or your patient with xeroderma pigmentosum, they're going to have a higher risk of melanoma than the general population. So again, keep those factors in mind.
So talking about the molecular pathogenesis here of melanoma, there are actually only about 10% of melanomas that arise as part of a genetic syndrome, like the CDKN2A mutations that Dr. Trevino was talking about. So that means that the majority of melanomas are sporadic. Okay, they don't have inherited mutations. There are 3 pathways molecularly that are thought to contribute to tumors of melanocytes. And we'll look at each of these in a little bit more detail. So the first, this is the one that is the most common cause of familial inherited causes of melanoma. It has to do with mutations in the CDKN2A gene. Okay, so this gene encodes 2 proteins. It encodes P16 and P14, and both of these are tumor suppressors. Okay, so if you lose a tumor suppressor, okay, because you have a mutation in the gene, then you're more likely to develop cancer. So the same theme that we've been talking about with the squamous cancers, right? This is just a slightly different gene, but the same thing. So that's one pathway. The other pathway has to do with this RAS protein kinase 3 pathway. Okay. Now this, I think, is easier to see in a diagram, which we'll look at the end here as a review. But the thing that's kind of neat, I think, about this is that melanomas that arise in sun-exposed skin have been shown to have a different molecular pathogenesis than melanomas that arise in non-sun-exposed skin. And I just think that's really fascinating. They obviously have different mechanisms responsible for them, and perhaps the treatment should be targeting different mechanisms because of that. Okay, so we'll look at this in more detail. And then, this is relatively new, but it's actually thought that the vast majority of sporadic melanomas have mutations in the telomerase gene. And you guys remember from your PBNT that telomerase is supposed to keep your cells alive, right? It prevents cellular senescence. So if you have activating mutations in that gene, you're more likely to, you're going to prevent apoptosis of those cells, predisposing you to getting cancer. This is a figure directly out of Robbins, and I have circled the genes and the proteins that I think are the most important when it comes to the pathogenesis of melanoma. And all of these are things that we've talked about. So here is your, this is the tyrosine kinase receptor sitting up here, which is often mutated in melanomas of non-sun exposed skin. And the reason we're looking at all of this, I think it's actually really fascinating because you can treat these people based on the molecular mechanisms for these, right? So here you can see that we have treatment that targets each of these different pathways here. But kind of look at the ones that we've circled. It goes through the RAS protein kinase 3 pathway, causing cellular survival, or the BRAF mutations, which cause increased cellular proliferation. Okay? I know this seems like a lot. Just spend some time looking at it, and it'll make sense, I promise. All right.
So as far as clinical presentation of melanomas, one of the things that we really educate folks about is the ABCDEs, and that's what I was talking about with the moles. Pointer doesn't work.
Oh, you.
That's okay. So anyway, A stands for asymmetry, B is border irregularity, C is color variation, D is diameter greater than 6 millimeters or operationally a little bit bigger than a pencil eraser. E is evolution. So say it started out small and flat and it got larger and raised. It's evolving over time. So those are things that we ask folks to look at when they're looking at individual moles and telling us if they've noticed any of those changes. The location of melanoma tends to be primarily truncal proximal extremities, more common in the trunk in men, lower extremities in women, lesser on the head and neck, fairly uncommon on the hands, feet, and digits, although significant, particularly in darker skin folks who don't tend to, you don't think about a high risk for developing skin cancers. Acral melanomas tend to develop folks with darker skin types, and then occasionally on mucosal surfaces as well. So part of our full skin exam should also include looking at the skin and any attached mucosa like the oral cavity and areas such as that. The types of melanomas, clinically, you can recognize these as, and we'll look at some clinical photos here, superficial spreading melanoma, nodular melanoma, which has a relatively short radial growth phase, but a rather rapid vertical growth phase, Lenigo-malignant melanoma, acral lentiginous melanoma. So these are clinical variants, but I want everybody to realize they're all melanomas, so they all have the same biologic behavior. So it's not like, oh, this person's better, going to do better because they have a Lenigo malignant melanoma as opposed to a superficial spreading melanoma. They're all melanomas. They're just clinical variants that have been identified over the years. Superficial spreading is the most frequently type of melanoma, and it most frequently, as I said before, it involves the trunk in males and usually the legs in females. So, when I'm looking at men, I really look very closely at their backs because although I'm going to look them, do a good exam all over, I tend to really look closely at their backs. Women, I definitely want to make sure that I look at the back of their legs because those are common areas where they tend to get them. And here you can see the superficial spreading melanoma. And again, sort of apply your ABCDEs to this, okay? And keep in mind that this is definitely bigger than 6 millimeters. So we've got a dark lesion, somewhat irregular, border, a little bit of variation in color. But again, they don't have to smack you in the face. I mean, this, somebody may be like, well, that doesn't look that atypical. And that's kind of the scary thing about melanoma. Sometimes they don't. Sometimes they look just a little different or kind of blend in with somebody's moles. And maybe there's just a historical feature about them that makes you a little more concerned. But again, sort of apply your ABCDEs to any mole that you're examining. Here again, a little bit darker mole that was a superficial spreading melanoma. Again, apply your ABCDEs. And you can sort of see in the photo here that this person also has sort of atypical looking nevi. Yeah, so sort of in the background of somebody who also has atypical nevi. Okay, I think this one, again, if you think about your ABCDEs, it'd be hard to justify that as being just a normal-looking mole. Okay, I think there's asymmetry, there's border irregularity, color variation, and it's a large mole. So again, this would definitely need to be biopsied. Nodular melanoma is most frequently on the trunk, head, and neck. And as I said, this evolves rapidly over 6 to 18 months into a raised nodule. So it doesn't grow out so much as it grows high. So it grows horizontally fairly fast. And it accounts for about 15 to 30% of melanomas. So I think you can appreciate here again, without the raised component, these moles look funny, but then you add in these nodular component that Dr. Krishnamurthy is circling there, and I think you could definitely say that these are not normal-looking moles. These are scary-looking moles that definitely need to be biopsied. Lentigo-malignant melanoma, this is a macular pigmented area on a sun-exposed surface. Typically, we think about this on the face. So we often see it in older folks who've had a lot of sun damage, and they'll have what looks like a big freckle. And you're like, wow, that's kind of a big, ugly-looking freckle. And sometimes that turns out to be a lentigo-malignant melanoma. And here's an example on a sun-exposed, this on a forehead. You can see this big thing that looks like a freckle. Again, it's got sort of a indistinct border, variation in pigment, and it actually has a nodule in it. So this is a lentigo-malignant melanoma. And then, as I said, acral lentiginous melanoma. Acral refers to the fact that it's on hands and feet, so-called acral skin. This is the most common form of melanoma in dark-skinned folks. So one of the things that I always remind everybody is when you're doing your skin exam, your self-exam, look at the bottom of your feet. Look at the bottom of your feet, sides of your feet, in between your toes, because you can develop skin cancer in those areas. Again, areas you typically wouldn't think about because for many of us, they don't get a whole lot of sun exposure, but especially in folks with darker skin, that's the most common area where they tend to develop melanoma. It can involve the palm, soles, nail beds. So if somebody has a very dark, broad streak in a nail, fingernail or toenail, that definitely gets my attention because I don't know if it's just a regular old mole. You certainly can have a regular mole or benign pigmentation of nails, but usually it's kind of a narrow, well-defined, one-color streak. But if somebody gets a broader streak that's like multicolored, and definitely if they have any pigment at the nail fold area, that gets me very nervous. So that's definitely going to get a biopsy. So here's an acral lentiginous melanoma, and again, you can see the variation in the pigmentation, and then actually an ulcerated nodule there. So again, something that certainly would demand a biopsy and a lot of concern about what you're going to find and what the prognosis might be. So evaluation of patients with suspected melanoma, again, we want to do a really good history, focused on the risk factors for melanoma development. We want to get a detailed history about the lesion in question, ask them about any potential systemic symptoms, weight loss, fatigue. On our full skin exam, focus on the ugly duckling lesion. So that's particularly in somebody who's got like a ton of moles, that patient that comes in with 50 or 100 moles. Obviously, you can't biopsy all 50 or 100, but generally they have a few that really kind of fall out. They don't look like the others. They look very different. So that ugly duckling lesion is definitely one that's going to get a biopsy. We want to do an excisional biopsy for suspicious lesions if possible. And that would be actually excising the lesion and a little bit of a rim around it, so I could send the whole thing to Dr. Krishnamurthy so she could take a look at that and give me information. It'd be very important in the potential treatment for that patient. And then certainly we want to do a good lymph node exam because we know melanoma could metastasize. So if I'm really concerned about a melanoma, I want to make sure that they don't clinically have any enlarged lymph nodes. So that would be part of our evaluation.
So that brings us to the pathology of melanoma. And as you know, when we talk about skin cancer in dermatopathology, I feel like there are not a lot of diagnoses that I make that are really going to kill people, but melanoma happens to be one of them. And as far as epidemiology, it seems, I diagnose at least one melanoma or melanoma in situ a week, that's here in Dayton, Ohio. So it's pretty, unfortunately, it's relatively prevalent. But okay, so we'll talk about melanoma in situ versus malignant melanoma. So the term malignant melanoma just refers to the fact we don't say invasive, but when we say melanoma, we're really talking about an invasive neoplasm of melanocytes. So on the left-hand side of the screen, you're seeing in situ melanoma. And this is a tumor. You remember when we were looking at normal skin, the histology of normal skin, you could barely see those melanocytes, right? Here you're seeing these big nests of cells, and a lot of them are higher up than they should be. Your normal melanocytes should sit down here at the basal layer, but here we have cells all the way up to the top. So we call that upward spread or pagetoid spread. If you ever hear that term, that's kind of a buzzword for the fact that this could be a melanoma. Okay. Now the difference between an in situ and an invasive or malignant melanoma, again, similar to the in situ and invasive squames that we looked at, in situ is above the basement membrane. So it's purely involving the epidermis. Malignant melanoma has now breached through the basement membrane, and it's now down in the dermis. Okay, so here is another view of a malignant melanoma. This is the in situ component, where you can see these nests of atypical looking cells that are percolating up high into the epidermis. So this is the in situ component, and all of this is down in the dermis. Okay, so this is a big, deep melanoma. This is going to be a bad tumor for this person. And some of the characteristics that we look at, I want you to kind of pay attention to this, and then we'll contrast it with benign nevi when we get to the next hour here. Okay, so you've got these big nests of melanocytes, which are about the same size at the top as they are down at the bottom. So we call that absence of maturation. Okay, and that's a bad sign in melanocytic tumors. It tells you it's possibly a melanoma. The other thing that this tumor has, when you look under higher power at those cells in the dermis, you will see these things. These are mitotic figures. So if you see a lot of mitotic figures, it tells you that the tumor is actively proliferating, and that usually is a sign that it's a malignant lesion, especially when it comes to melanocytes. And then this is not always true, but the textbooks always talk about the classic appearance of melanoma as having a cherry red nucleolus, and that's this is a cherry red nucleolus. But really kind of pay attention to the fact that you have atypical cells percolating up into the epidermis and down into the dermis. They're all large, they're highly proliferative. This is a bad tumor. This is malignant melanoma. Yes?
When you take a biopsy of something and you diagnose it as carcinoma in situ, how can you be like 100% confident that on your two-dimensional cut, you didn't, miss another area that actually did invade the basement?
That is an excellent question. And, you're never 100% sure is really the answer, which is why most of the times what we look at, like if I see something under the microscope that doesn't quite match with the clinical picture that Dr. Trevino may be giving me, I will go back to that block and cut deeper into it to make sure we're not missing anything, which I think is part of the challenge of skin pathology,
Sure.
The fact that you really have to correlate what you're seeing clinically with
And
what you're seeing.
Conversely, if I get a path report back that doesn't really fit what I thought, like I thought it was an invasive squamous cell, and I get back squamous cell in situ, I'm going to call Dr. Krishnamurthy and say, hey, could you keep cutting through the block and make sure that you don't see any invasion? So I think a lot of this is you have to do a good clinical path correlation. I mean, your clinician and your pathologist really need to work well together because that's the way you're going to do the best for your patient, is by making sure that we're exchanging information. So that's a really good question because that's definitely a point that comes up.
Yes. 2 slides. Uh-huh. Yes, all of these are melanocytes. I know, it's sometimes hard. When I first started out, I had a hard time telling if those were melanocytes or lymphocytes. I mean, for your purposes, so some of the clues that you may have here are the fact that you have pigment up here, right? So when you see melanin pigment, that's usually a good clue that those are probably melanocytes. I don't want to go into a whole lot of detail here, but look up in the epidermis. If you see these cells percolating up, that's a good clue that they may be melanocytes. And then when you look down here, you could get this confused, I guess, with a squamous cell cancer. The difference between a squamous cell cancer and a melanoma is that this is not as pink. You're not seeing all the keratin that you saw in the squamous cancer, right? I don't know if that answered your question. Did it? Okay. Yeah, so these are all melanocytes down here in the dermis, which makes it a melanoma. All right. Okay, so now we're going to briefly talk about the radial and the vertical growth phases of melanoma, which Dr. Trevino touched upon earlier when he was talking about the nodular melanoma. When I was a second-year medical student, I was pretty much taught that the clinical subtyping, has significant prognostic relevance. So, for example, a nodular melanoma is the most deadly of the types of melanoma, versus an lenticle maligna doesn't do so badly, right? We now know that if you look at the Breslow depth, that is really the most important prognostic feature for melanoma. And the reason, if you study nodular melanomas, the reason these people tend to do worse is because those tumors tend to be deeper than some of the other subtypes of melanoma, So it really, the clinical subtypes are really just what it looks like. The prognosis is going to depend on how deep do those melanocytes go into the dermis. Okay, so radial versus vertical growth phase. Radial growth phase implies spreading out horizontally within the epidermis. So this is your radial growth phase. Vertical growth phase is the vertical spread down into the dermis, and this is what we measure when we talk about the Breslow thickness. Okay, so for a melanoma, Breslow thickness is measured from the top of the granular layer to the very bottom of the deepest invasive nest. It's a measurement that's given in millimeters, and that is very important for the staging of your melanoma. Okay, and that Breslow really is your vertical thickness here. So this is something that, again, Dr. Trevino talked to you about. When it comes to if you have a suspicious lesion on your patient and you're pretty worried that this is a melanoma, you want to either do an excisional biopsy, so you're taking some normal skin along with the entire lesion, or if you're going to do a shave biopsy, you want to kind of go deeper. You want to do like a scoop shave, which you'll learn about when you're out in the clinics. But the reason, so why do you want to do that? Why don't you just want to cut it off superficially or punch just the middle of this lesion? Exactly. So if you just cut it out superficially, I can't tell you, if there's cancer deeper down, and we really want that Breslow depth to determine how badly this tumor is going to do and how you're going to treat it, right? So we can't just superficially shave it off. And if we just do a punch right in the middle, I don't get to see what it looks like on the outside, and I can't really give you a good diagnosis of melanoma,
right.
Okay? So when you're doing this, make sure you get some normal skin around a pigmented lesion. Okay. So prognosis for melanoma, this is actually true for any cancer. This is just a generalization. Any cancer, the most important prognostic feature is going to be the stage of the tumor. But when it comes to localized melanoma, so this is a melanoma that has not yet spread out into the lymph nodes or out to distant organs, now the most important prognostic feature is that Breslow thickness or the depth that we were talking about, okay? The two other things that you'll see in a pathology report that do have prognostic significance are the ulceration. So a tumor that's ulcerated tends to do much worse. And mitotic activity, that's something else that goes into the staging of a melanoma, okay? So this diagram, I think, nicely illustrates why you really want to catch these patients early, okay? So stage 1 melanomas, these are kind of the thin melanomas that are less than 1 millimeter in Breslow thickness. So both stage 1 and stage 2 melanomas are localized to the skin. They have not metastasized to the lymph nodes. Stage 3, this is when the tumor cells are out in regional lymph nodes. And stage 4 is if it's in a distant lymph node or some other organ. So you'll see here a patient with a stage 1 melanoma, 10 years down the line, like 98% of them are going to survive. Versus a stage 4 melanoma, I mean, look at that. That's less than 10%. So that's a huge deal. So you really pay attention to those pigmented lesions in your patients.
So as far as treatment, and just aside, one of the ways that I remember the prognostic factors is I think having melanoma is a bummer. So I think of BUM, Breslow, ulceration, mitoses. I don't know if that helps you at all, but those are kind of the big prognostic things that Dr. Krishnamurthy is going to come up with is the Breslow depth, ulceration, mitoses. So that helps me remember what are the most important factors. As far as treatment, Dr. Krishnamurthy just kind of outlined stage 1, 2 local disease. The standard treatment is going to be surgical excision with a 1 to 3 centimeter margin, depending on the thickness. So as the tumor gets thicker, your margin becomes a little greater. You want to consider a sentinel lymph node biopsy in tumors that are greater than 1 millimeter Breslow depth. And we'll talk here about a sentinel lymph node biopsy in a second. So yeah, basically what a sentinel lymph node biopsy is, you try to identify the draining lymph node basin for that, where that particular tumor happens to be. And then the patient actually goes to the operating room, and a radioactive substance with blue dye is injected near the tumor. And then the injected material is detected visually with a probe that detects the radioactivity. And then that kind of tells you what node is the first one to take up this dye or this radioactive tracer. And then you basically excise that node, and then you send it to the pathologist so they can look at it and see if there's any cancer cells there. So this is basically a prognostic type of a test to see if there's been any spread microscopically into those adjacent draining lymph nodes. This is something that, again, we work with surgical oncologists. I do not do this procedure as a dermatologist, certainly have patients that have undergone it, and I've worked in conjunction with other doctors. There is some morbidity to it because you're taking out a lymph node, so it's not something that we just jump to, but it certainly for some patients can be very important in providing them with some prognostic information. If they have a negative sentinel lymph node, that does tend to portend a better prognosis than somebody who has a positive sentinel lymph node. So again, just another adjunctive procedure for patients generally with a melanoma that's greater than 1 millimeter in thickness would be the ones that would get a sentinel lymph node. Stage 3 being regional metastatic disease. Again, the sentinel lymph node biopsy could be done, and they're often offered adjuvant therapy with alpha interferon, has been shown to prolong the relapse-free survival in patients with these higher risk melanomas. Stage 4 disease, as Dr. Krishnamurthy said, that's where distant metastasis. So these are really, as we get into stage 3 and 4, I would again tell you that those patients are going to be handled more by surgical oncologists and medical oncologists than by, say, a dermatologist. A dermatologist certainly could handle a stage 1, but we're going to be referring those patients out with systemic involvement because they may potentially need systemic therapies. So in these folks, emphasis on palliative therapy with special emphasis on quality of life, and then oral chemotherapeutic agents and resection of metastases may be indicated. And one of the things is that in recent years, there's actually been a lot of excitement because there's actually some really interesting, novel, and directed therapies now for melanoma. I'd say for a number of years, melanoma really didn't have any good chemotherapy or immunotherapy available. There was just standard chemotherapy that was being used for metastatic melanomas, which was not really having a significant impact on survival. There's now been a number of different medications that have been developed in the last few years that are targeted therapies that definitely have gotten a lot more excitement amongst folks in terms of prolonging survival. So we have a couple different categories. You have your immunotherapy, you have ipilimumab, which is a humanized anti-CTLA-4 monoclonal antibody, and you have pembrolizumab, which is a PD-1 inhibitor. And then some of the targeted therapies, you have the vengurafimab, and that targets the V600E mutation in BRAF pathway that Dr. Krishnamurthy showed you. The drafabinib is also a BRAF inhibitor, and then you have trametinib, which is a MEK inhibitor. So I probably take this list, go back to your diagram, and kind of look to see where they fit on those pathways. Because again, I think the cool thing about these is they're actually targeting key steps in the pathway on the pathogenesis to melanoma. So potentially, I think that they can really impact the survival in some of these folks. Again, I don't prescribe these drugs. These are drugs that I might refer a patient, and as I'm following them, I'll often follow them for subsequent skin checks and lymph node checks, but I'll see that the oncologist maybe has them on these drugs, so I'm definitely familiar with them. I don't prescribe them. Okay, so we're on to skin cancer prevention. I think that's me.
Yes.
All right, okay, so certainly, we talked a lot about skin cancers, particularly melanoma, and the important part in terms of prevention of skin cancers, because if we can prevent skin cancers and reduce the risk, we're obviously going to reduce the morbidity and skin cancer deaths by doing this. So just a few tips that I think are really important for folks to remember. Try to avoid UV exposure as much as possible between 10 and 4. That doesn't mean you have to be inside all the time, but you do want to be mindful if you're going to be out doing outdoor activities during those times, because that's when you're going to get the peak of the ultraviolet radiation. So what can you do? You can wear protective clothing, including a broad-brimmed hat. A cap is okay. A cap is better than nothing, but remember, that still exposes your ears. And I can't tell you how many folks I've seen with skin cancers on their ears. And I've been working out at the Veterans Hospital for a number of years. I have a lot of guys that come in with funny-looking ears because they've had to have part of their ear cut off in order to treat a skin cancer. So broad-brimmed hat is a really good thing to wear and save your ears over the years. Certainly you want to be vigilant with kids because kids are a little more sensitive to UV exposure. And again, I feel like if we can start kids early on, if parents can emphasize the importance of sun exposure to kids early on, then kids kind of take that and run with it. So I have a number of parents that bring their kids in, and their kids are telling them, Mom, you have to put my sunscreen on, or we have to put the sunscreen on now. So like I say, I think if we can educate kids early on, we can definitely impact that skin cancer rate, because as you saw, 25% of your total sun exposure is below the age of 18. So if you don't really become aware of this until you're an adult, then you've already probably caused a fair amount of damage. So trying to educate folks early on, I think, is really important. Avoid indoor tanning. So, I think you would expect a dermatologist to get up here and tell you this, but certainly indoor tanning, I think, is a potential danger. And as of September 2nd, 2014, the ultraviolet tanning devices were reclassified by the FDA from Class 1 to Class 2, which means that they recognize that there really is a potential higher risk for indoor tanning. So I would definitely caution folks about this and just tell you, I've seen a number of patients that come in with melanoma that it's probably attributable to indoor tanning. So I think that that's another really good reason to be really cautious about this, to educate your friends, family, and patients about this as well. Sunscreens. I think sunscreens are really a good way to reduce your skin cancer risk, and routinely using a sunscreen SPF 30 or greater. SPF is the amount of UVB protection. So remember, ultraviolet light is a whole big spectrum. You have your shorter waves, which are your UVB, and your longer waves, which are your UVA. SPF is just a sort of a scale that they came up with to indicate the amount of UVB protection. So when you're looking at a sunscreen and it tells you the SPF, that's telling you the UVB protection. There's no analogous scale for UVA protection as of right now. So it's not like you get a UVB protection number and a UVA protection number. However, they have mandated that they can label sunscreens as being broad spectrum. Broad spectrum sunscreens have to demonstrate that they do cover both UVA and UVB. So I recommend that folks go out and get a broad spectrum sunscreen. And there's a number of different sunscreening agents that I think are really good. I'm not necessarily recommend a certain brand of sunscreen. I don't think that's important. I think it's important what's in it. So certainly some of your physical blockers, titanium dioxide, zinc oxide, I think are really good because they cover the whole ultraviolet spectrum. They're physically blocking ultraviolet light. So they're micronized, they rub into the skin, they look clear. After you rub them in, they don't leave a white film. So I generally recommend folks get a sunscreen with one of these physical blockers. The savobenzone is also a really good UVA blocker, so that's a nice ingredient to have in, as well as Mixoryl. That's another really good blocker. You want to apply sunscreens liberally and reapply every 2 to 3 hours. So even if it says it's waterproof, it lasts 6 to 8 hours, you put it on one time, you're good for the whole day, it's probably not accurate. So I'd recommend that you apply more than you think you need and reapply it every couple hours, particularly if you're sweating. So again, okay, so sunscreen blocks your UV light. Your SPF is the time in the sun to get a sunburn with the product over the time in the sun to get a sunburn without the product. So if it takes 10 minutes to get a sunburn without and 150 to get it with, you put 150 over 10, you get an SPF of 15. Okay, so SPF tells you how much of what is blocked. Do you remember? UVB, yeah. SPF is only a scale telling you how much UVB is blocked. So yes, UVB. Okay, and one of the things to remember is that there's not a kind of correlation between your SPF and the amount of blockage. SPF 15 is going to block 93.3% of UVB. SPF 30 doesn't block twice as much. It gets you up a couple percentages to 96.7. So you can see there's a little bit of incremental increase by going from a 15 to a 30. And again, SPF doesn't tell you how much UVA is blocked. But if the sunscreen is labeled a broad spectrum sunscreen, it should cover both UVA and UVB. Generally, I'll recommend somebody get an sunscreen, broad spectrum sunscreen, SPF 30 to 50. So if somebody's fairly pigmented, has a little bit darker skin, I think a 30 is fine. If somebody's one of those type 1 or type 2 folks, very fair skin, red hair, blue or green eyes, then I'll tell them to get a 50. They've actually shown that if you go above a 50, you're really not gaining a significant amount in sun protection. So I don't think you have to get 100 or 120 or some crazy number like that, but I think the range of 30 to 50 is a good general recommendation for yourself, your family, friends, patients. Just a couple of the sunscreen agents here, and again, I tend to really like these physical blockers, so I think you want to find one that has a titanium dioxide or zinc oxide, and again, some of the UVA blockers to make sure you get the UVA, I think is also really good. Okay, so the physical blockers, as I said, they physically block ultraviolet light, so they get both UVA and UVB, and that's why I tend to recommend those. And just as a conclusion, one of the things that we do as a community service project every year is we do a series of free skin cancer screenings around the community. So we have a week, you guys probably aren't aware, but May is Skin Cancer Detection Prevention Month. You can put that on your calendar. And the first Monday in May is Melanoma Monday. So that's to remind us about the importance of melanoma. So in conjunction with that, we do a free skin cancer screening where we have a series of clinics throughout the community. Anybody can sign up to come. There's no cost. So we see folks that maybe don't have a dermatologist, don't really have access to medical care, come in. We give them a really good skin exam. And then if we see something concerning, we refer them off to a physician that can help them with that. And I personally have caught a couple melanomas during those skin cancer screening clinics, and I still see some of those patients. They continue to come back years later, and every time I see them, they're like, thanks for catching that at the screening. So it's a really great project. If any of you guys have the opportunity, time, and you want to get involved, we'd love to have you. But again, I think this is just a good way that we can help as physicians to decrease that risk for thicker melanomas and help patients have a longer, healthier life. So that's it.
Great. So Dr. Trevino and I will be down here, and we'll start our next talk at 10. So you have 15 minutes.
Just in terms of like prognosis, because I know you guys have to